So next up, we have restrictive cardiomyopathy and the underlying causes. And the treatment, of course, is to address the underlying disease in heart failure. So which is why it's important to find out the underlying cause of non-ischemic cardiomyopathy. First, we have amyloid. Of course, you'll see other findings of amyloidosis like renal, neurologic, and hepatic dysfunction. And on ECG, we see decreased voltage, and the underlying diagnosis is obtained with cardiac MRI. Second, we have hemochromatosis. Family history is important and presents in males earlier onset and in females later onset as well. And you'll, of course, see the other presentations of hemochromatosis like increased LFTs, arthralgias, diabetes. On echocardiogram, usually seen a dilated left ventricle with global systolic dysfunction. And cardiac MRI can be important for diagnosing as well with iron overload with T2 protocol. And third, sarcoidosis. Again, important to look at the whole picture and other symptoms as well, especially in patients who have undiagnosed sarcoidosis, usually present in young adults. Sometimes you can see infrahisian blocks as well, an atypical infarct pattern. And on echo, variable wall thickness, focal or global hypokinesis, and sometimes LV aneurysm as well. And cardiac MRI can show characteristic findings of patchy enhancement of basal and LV walls. So kind of a trend in these patients, all of non-ischemic cardiomyopathy, that you have a restrictive cardiomyopathy. Getting cardiac MRI would be important to characterize the disease and find the underlying cause. The next series, we'll be talking about inpatient acute decompensated heart failure, kind of the treatment on the floors and in the intensive care unit, and seeing the different types of cardiogenic shock, SCAI criteria, and the management.